Welcome to the Holistic Plastic Surgery Show, where we dive deep into the hottest trends in health, beauty, and cosmetic treatments. I'm Dr. Anthony Youn, America's holistic plastic surgeon. Well, have you ever wanted to change the shape of your breasts? According to the American Society for Aesthetic Plastic Surgery, last year over 500,000 Americans had their breasts enlarged, lifted, or reduced. Although it seems like just about every celebrity in Hollywood has undergone a breast augmentation, there's a lot more to breast enhancement than most people realize. Did you know that smoking can make your nipples fall off? Or that the scars from a breast lift are permanent and longer than the scars from a tummy tuck? Or that there are currently hundreds of shapes and sizes of breast implants to choose from? And maybe you didn't know that doctors of all kinds, from ER docs to ophthalmologists to ENTs to oral surgeons, are putting breast implants into women all around the country. It's definitely a buyer beware market. But don't worry, this week's guest and I have the information that you need to help you make the right decision for you and your breasts. So let's get started. My guest this week obtained her MD from the University of Toronto. After finishing her plastic surgery residency training at the University of Manitoba, she then completed a fellowship in reconstructive microsurgery at the famous Bunkie Clinic in San Francisco. My guest is internationally certified in plastic surgery by both the American Board of Plastic Surgery and the Canadian Royal College of Surgeons. She is an invited guest speaker at several national meetings, has published book chapters and many scientific articles, and is recognized as one of the most prominent female plastic surgeons in the United States. Based in the San Francisco Bay Area, my guest specializes in rejuvenation of the breasts and body for women who have completed child rearing, also known as the mommy makeover. Her practice also centers on providing beautiful, natural, and long-lasting results for breast cancer survivors using microsurgery or single-stage implant reconstruction. I'd like to welcome board-certified plastic surgeon, Dr. Karen Horton, to the Holistic Plastic Surgery Show. Well, thank you so much for coming on the show. I'm really excited to talk about this very hot topic in plastic surgery. Breast enhancement, like I mentioned earlier, is one of the most popular cosmetic surgeries. And I know that you do a lot of this in your practice.
I do. Thank you so much for having me.
Thank you. Okay, well, let's just get started by talking about your practice so that our listeners and our viewers can get to know you and what you do in practice. What type of practice do you have? What types of patients do you see and procedures do you do?
So I'm in practice in San Francisco, and my practice is a balance between both reconstructive surgery of the breast and cosmetic surgery. I always say basically from the cheekbones down, because a lot of the upper face stuff we can do with Botox. Mm-hmm. I do all types of breast surgery, both breast reductions, breast lifts, breast augmentation, sometimes a combination. And then I also specialize in several types of breast cancer reconstruction that either save major muscles of the body using microsurgery or using implants in a single stage where we also save the pectoralis major muscle. And I also see a lot of moms. I'm a mom myself of twins, and I do a lot of mommy makeover surgery, which is just a catchy way of describing rejuvenation of the breast and the body, or sometimes other areas of the body after a woman has finished having children.
So let's go ahead and start on kind of the major topic of today, which is breast augmentation or breast enhancement. If somebody is interested in making their breasts larger, either they've never had the breasts that they've wanted, and now they're in the position to get them, basically, or let's say they've had children and their breasts have changed a lot. If they were to enter your practice, come in as a new patient, how would their experience be? You know, starting from walking in, if you could kind of educate our listeners, what is it like to come in for a consultation, and what are the steps after that leading up to the surgery and the recovery?
Okay. So having a breast augmentation is something that's very personal for women because a woman's breast really, it signifies their femininity. And just as you said, some women are born with very small breasts. They might feel like they're out of proportion with the rest of their body, or they may have had changes after pregnancy or sometimes after major weight loss. So the first thing I do after I get to know my patients, head to toe, inside and out, is I say, if I could wave a magic wand and if I could make your breasts any way, tell me what you're going for. And usually it starts off with a conversation about cup size, but I always say, just don't worry about the cup size because that really doesn't matter. You might be a B in one bra, a C in another bra, and if you go to Nordstrom, they might fit somebody as a double D, and they might go, oh no, I don't want to be that big. So it's really about the proportion. It's about the look and how does their breast, their top match their bottom. And so I give patients homework. You know, when I started my practice 12 years ago, we didn't have as many resources online. Really, there was Playboy, but a lot of patients don't really want to look like that. They just want to look natural. They want to be proportional. So I tell patients, show me what you're going for. This is going to be a very personalized surgery. We want you to get the exact look that you're going for. So do a Google image search and type in whatever keywords are giving you pictures of nude breasts that corresponds to what you're going for. It might be B cup or C cup or full or natural or teardrop. And find pictures that you like. You're not going to see tons of pictures of breasts, and some really won't be what you like. You might see porn. But within those, right-click, save as, show me your wish pictures and save some yes pictures. That helps me to understand what's in my patient's mind's eye and what are they going for. In addition to yes pictures, I want them to find me some no pictures. I definitely don't want that. That's too big or too round, too fake, too droopy, too wide. So that way I have a really good idea what the patient's going for.
And one thing I do, and I think that's a great idea, because I have patients all the time who will bring in photos of, oh, I want to look this way or that way. But I think the problem that I find sometimes, it's not really a problem, but I think something that's, I think, important to help educate patients with is how important it is to realize how you look like before surgery. Because, you know, I mean, anybody can bring up a picture of a Playboy model or something and say, hey, I want to look like that. Just like when we do nose jobs and say, oh, I want this person's nose. But if your nose doesn't start out looking something like that, or if your breasts look very different than that person's did before their implants, then that's going to be a problem. And so one thing that I do for patients is I say, hey, look, one way to do it is to take a picture of your torso. Just take a selfie with your camera on yourself. Take a picture of your torso. Don't put your head in it, your face, nothing like that. Print it out at home and tape it to your computer screen. And compare how you look now to the before photos on, let's say, doctors' websites, and try to find somebody who looks like your before photo, and then find somebody that looks like your before and has the after that you're looking for.
That's a brilliant way of doing it. Well, I also ask patients, I say, try to find someone who has a similar frame to you. You know, some patients are aware of their body type and others maybe are not. But that's a brilliant way of doing it. And so, yeah, the whole wish picture concept, it helps me understand the little subtleties of what patients are going for.
And I think
so that's great.
We look at I'm going
to use that.
We look at our bodies individually, I think, very differently than what other people may see. And I think that's what I find is that I'll ask patients, hey, you know, do you notice that you're asymmetric, that literally one nipple is 3 centimeters, like, you know, 1.5 inches higher than the other one? I go, no, I never noticed that. But 100% you're going to notice it after surgery, because you may look at your breasts 2 or 3 times a day before surgery. After surgery, you'll be looking at them 20 or 30 times a day, and you're going to point this out. And if I didn't tell you this, then you'd say, well, why did Dr. Youn put my nipple up higher on that one side?
Right. No, that's absolutely true. And we do have a different relationship with our body when we look down or when we look in the mirror versus when you look at a printed out photo, you really can see all the differences. So I also do that. I point out any asymmetries, you know, maybe this breast, the fold's a little higher one side than the other, nipples can be different. And it's important for patients to understand their canvas that they're starting with. They show me what their vision is, and then we have to find the best way to get the patient from where she's starting to where she shows me she wants to go. So in my practice, wish pictures are the first step.
Do you use 3D imaging? Like the Vectra or the Axis?
No, you know, it looks interesting. It's fancy, but the thing is, it's not real. And I think once a patient sees a picture printed out, their body morphed, that's what they're expecting. So I personally don't use that. I know it's a really neat tool, and a lot of surgeons find benefit in it. But that's our first step. So our first consultation is usually about an hour when we're talking about breast augmentation. We go over all the different options, all the different implants, you know, the placement over and under the muscle. I tell patients all about my philosophy, and then they go home, they think about it, and I invite them to email me their yes and no pictures anytime. Then they come back for a preoperative visit. And at the preoperative visit, they spend about an hour and a half total in my office. They spend some time with Nurse Mary, who educates them about their recovery and restrictions. And, you know, she reminds them about all their recovery details. And then I will go over with the patient their wish pictures. And at that time, I will take pictures of them. And then I'll have a better idea of exactly what implant type and any other details. Do we need to do a lift? Do we need to do any other details of surgery to get them where they want to go. And I'll have a better idea at that time of maybe the range of implant sizes, how much width, how much projection. And we'll talk about what I'm thinking, but I will describe to them that I'm actually going to use their wish pictures intraoperatively when they're asleep. I have a whole gallery of breasts up on the wall. Yeah. And I'll have their preoperative photos that I'll take just from the neck down. And again, I'll have a ballpark idea, but I will put in a sizer when they're asleep that I can inflate, deflate to all different volumes. We sit the back of the operating room table up, and I can see in that patient's body, real time, 90 degrees before there's any swelling, what do we need to give them that much projection? How much upper pole fullness? How much lower pole? Do we need to lift the nipples? So I'll tell patients, I'll get you as close as humanly possible to what you show me, but don't get fixated on the cup size because that doesn't really matter.
Yeah, so you don't have them use sizers like in the office, like inserts into a bra?
No, I don't, because I think especially, for a small-breasted woman who has a very dense breast, it could give you an idea, but for a woman who has really empty, deflated breasts, an implant on top of the breast in a bra is not the same thing as an implant filling out the space. Also, I do a lot of tubular breast reconstructions, and a tubular breast is one which is small, very widely spaced, a high fold. They have what's called pseudotosis, where they look a little droopy, even though they're not. And so in that case, we're really relying on the implant to make up the whole shape of the breast, and we're really changing the breast architecture. So in those cases, it's really important for me to see the vision of what they're going for, because an implant on top is not going to show us that.
Okay. As far as, there's so many implants out there nowadays, and it seems like every month there's a new style out there. Is there a certain type of breast implant that you tend towards liking?
So I do prefer silicone over saline. I will use a saline implant for breast reconstruction because I want the implant to be adjustable after surgery. But for cosmetic surgery, or if we know that there's only going to be one surgery to get the outcome, then I do prefer silicone. Silicone has a much more natural look and feel. It's flowy, it's soft, just like natural breast tissue. They're so nice. So I do recommend silicone because I want my patients to have the most natural results. We shouldn't be able to see the implant, and we shouldn't be able to feel the implant. The purpose of the implant is just to project your own breast tissue forward, or maybe to replace breast tissue that is missing. In terms of the style of implant, we have some implants that are really wide and flat, and they look like little flat pancakes. I will use those on occasion. We have some that are more middle of the road, and then we have some other ones that are very high profile and very projecting. So the width and the projection, that really is determined based on the canvas that the patient is starting with and where she wants to go. But in all cases, I do prefer a smooth-walled implant. There are some implant shells that are smooth, and I like the smooth surface because we actually want it to move around very subtly when it's in the pocket. When a woman's body changes position, we want the implant to change position with her, and it actually will change shape from a teardrop shape when she's upright to flat when she's lying down. So that's the implant that I prefer because I want it to be mobile and natural. There is another implant which looks amazing, but I'm actually not a big fan of it. It is a shaped implant, and being trained in Canada, I actually had access to this implant about 20 years ago. So I do have a lot of experience with it. I know a lot of surgeons like it. My preference is not. Even though it looks great because it's shaped, when you put it in the body, there's a risk that it might turn and rotate. So in order to prevent that rotation, the implant manufacturers made a textured surface. The problem that I find with the textured surface is that when it's in the body grows scar tissue onto it like Velcro. It doesn't move. And even though it feels pretty soft and squishy outside the body, when it's in the body, it actually feels more like a pencil eraser. And I get to know my patients so well. And when I was using these implants during my training, I asked patients, how are they working for you? Have you had to change any of your activities? And they would describe that they felt really firm if they were lying on their chest, getting a massage or doing yoga or Pilates. And even though they look great, they were a little bit too firm. So I'm not a fan of the shaped implants and the texturing. But there's one other thing that is now leading me to stay away from textured surfaces. And that's the development of
Let's get into that in just a second, if that's okay, because that's a subject I really want to cover. I just wanted to insert in here that I am 100% in agreement with you. I think in the last, I've been in practice 14 years now. I think I put in for first-time cosmetic plastic surgery patients, I think I put in 2 shaped textured implants. And one of those, I really didn't like the result. Patient was happy, but it wasn't my thing. And I agree with you. I think that the soft-walled implants or the smooth-walled implants are made to move. They're made to feel more natural. And I call it the hug test. You know, if you don't have a bra on and you hug somebody, are they gonna know you have implants, or are they gonna have no idea? And that's what we want.
Brilliant.
We want them to pass this hug test. And too many times the textured implants won't. And I can't tell you, Karen, how many textured saline or silicone implants that I've taken out and replaced with smooth-walled silicone, even smooth-walled saline. And patients go, oh my gosh, I didn't know that they could feel like this.
Yeah.
I thought they were supposed to feel rock hard all this time.
Yeah, I agree. Yeah, I perform the hug test every day just with other moms and other women that I know and patients. And sometimes I'll hug somebody, I'll go, oh, they have implants. They have grade 2 or grade 3 capsular contracture.
There you go. And that really, I mean, it can really affect people. I've had patients that have said, you know, I feel, you know, they've got a capsular contracture, but sometimes you don't even know, is it a capsular contracture or is it a textured implant? You can't tell because they both feel so firm. And once again, they say, look, I feel so self-conscious when I go hug somebody at a wedding or a funeral or at a party. And so I don't. And it's real odd. And then you switch them out and they go, oh my God, like I'm a hugger now.
Yeah. No, I agree. And, you know, it's interesting because a lot of the European surgeons actually prefer textured implants.
I don't get it.
I'm not sure why. I've been presenting at a lot of international breast meetings in the last few years. And it's really interesting the difference in demographic between, you know, Northern California, Southern California, some parts of the U.S., but even U.S. compared to Europe. And textured implants are very popular in other parts of the world. I'm not saying they're bad. It's just I wouldn't want them in my body, and I don't prefer them for my patients.
Yeah, I don't get it either. It just it does make sense to me, but what can we do? So now, in the last couple of years, we have heard a little more research coming out about a very concerning type of cancer in the scar tissue around the implant, which has made me so glad that I haven't been using these implants. So can you kind of describe the whole issue with ALCL? Some of our patients have heard about it. There have been some recent New York Times articles on it. I actually did a YouTube video.
So ALCL.
Oh, real quick, I did a YouTube video where I kind of explained my thoughts on it. But if you can briefly explain what your thoughts are and kind of what this is.
Definitely. So ALCL stands for anaplastic large cell lymphoma. And this is a very, very rare subtype of lymphoma, similar to Hodgkin's lymphoma, which has been found associated with some types of breast implants. It's something that I've been following the science and the research for years. I've been tweeting about it with the hashtag ALCL. So it's not new to me, but so about a month or two ago, NBC dropped a story about 9 women dying because they had breast implants. And patients started calling my office very concerned. And their question was, do I have textured implants? So I think it's good that this story is getting out there. Unfortunately, media loves to fearmonger and they love to spread stories that are sensational. And we all know that there was bad press with breast implants back in the 80s and the 90s. And it's such an emotional and a visceral topic. The deal with ALCL is I've never seen a case. I probably never will. But it is a very rare subtype of abnormal cells that can form around a breast implant. And things to watch for are if you've had a breast implant for generally greater than 10 years, if you were to have sudden swelling of your breast and fluid accumulation around the implant, that's not normal. And you should either go back and see your plastic surgeon or see a plastic surgeon who does a lot of breast surgery. The treatment first is to take a sample of the fluid, and you would need to test it for a particular marker. It's called CD30. If it's confirmed to be ALCL cells around the implant, the treatment is removal of the implant and removal of the capsule of the scar tissue. And generally, that's curative. We are still identifying which implants are they associated with. And back when I last looked at the numbers, there was 359 cases identified. Of those where the implant was known, the majority of them were textured. So that also is one reason why I stay away from textured breast implants. But it's rare. It is usually curative by surgery. It's something that really we should all be aware of. And if you do have breast implants, if you have textured implants, the message is don't panic. You don't need to have more surgery. You don't need to have them removed. But I think it's important for any woman with a breast implant, which is essentially a foreign body. It's an implantable device. It's a medical device. They need to be aware of what implant they have and signs of problems in the future.
Yeah, and I think you're completely on target. One of the things that I would add to that is that there have been some deaths reported from this ALCL, which is extremely scary for, a complication really of a cosmetic procedure. In what my understanding is in those situations, typically the patient may not have been treated in the most, how would I say it, in the most scientifically studied way that we know now. And so what has happened, I think, in some of those cases at least, is that we have scar tissue around the implant, and that scar tissue needs to be 100% removed during that surgery to try to cure it. And in some of those cases, only the front part of the scar tissue is removed because the back part of the scar tissue can be very adherent to the ribs. And as you and I know, it can be quite a bloody and involved operation to take that part off. But if there's still that ALCL, that cancer in that scar tissue that's attached to the ribs, it actually grows into the ribs potentially, and that's where people have really had major problems. And so kind of one of the big things is that, and obviously the textured implants. And to our knowledge, currently, there are no cases of patients with just a history of smooth implants that have developed ALCL. Now, they may come in the future. We don't know. But of all the cases, which are over 300 that we know of, the patients all had some type of history of textured implants. And so,
right. Yeah.
So, but we don't, it's still so early, as you and I know, with studying this.
And you think about all the women who do have implants, all the women who have textured breast implants, and most of them are totally fine. But it's unusual, and it's really good to just have awareness so that if you ever do have something abnormal with your breast, you just get it checked out. Just don't ignore it.
Okay, well, let's shift away from breast implants, and I'd like to see what your thoughts are with fat injections to the breasts. So this has been a hot topic the last 5-10 years or so. Some doctors are saying, hey, let's just inject fat into the breast. You don't need implants. Are you doing that? And what are your thoughts on it?
So fat grafting to the breast is definitely a hot topic and is controversial. I do fat grafting all the time as part of breast cancer reconstruction. And I think it's a really great way. Say a woman has had a mastectomy, she might have an implant, or even if she's had a flap, sometimes there can be a little hollow up here. So it's a really great way to add a little bit of fat up there and help fill it in, although it's not magic, and you cannot build a whole breast only with fat grafting. Fat grafting involves doing liposuction and harvesting fat from one part of the body, taking that fat and sometimes washing it and concentrating it, and then injecting it under the skin. The problem with fat grafting is I describe it as like sprinkling grass seed. Some of it will pick up a blood supply and stay, and some of it will not make it and go away. And we can really only rely on about 30%, maybe up to 50% in some cases, of the fat cells picking up a new blood supply and surviving. The problem with the fat cells that do not survive is when they die, they can calcify and they can create calcifications within the breast, which is exactly what a mammogram looks for when it's screening for breast cancer. Also, the fat can kind of accumulate and form oil cysts. And there are some surgeons who have heard about fat grafting. Maybe they don't do a lot of breast cancer reconstruction and they're not thinking about the long-term consequences. But I have seen at some national meetings a mammogram that goes up and it looks like an entire snowstorm of calcifications. And the question is, how are we going to screen this patient for breast cancer? Is she going to have unnecessary biopsies, either false positives, or is a radiologist going to assume, oh, that little cluster of calcifications, oh, that's probably related to fat grafting, and ignore cancer? So in my practice, I don't currently offer it. I know a lot of plastic surgeons do. I say, just do it with, together with your radiologist. Make sure that if there is a finding on a mammogram, that the woman can be screened appropriately. So it is controversial. Also, it's, putting in an implant is reversible. If you don't like it, you can remove them. You can go right back to where you started. And the imaging technology can really see the difference between your breast tissue and the implant. It's really clear cut. So I think that fat grafting to the breast is something that it will probably continue. But currently, I don't recommend it to my patients just for safety and screening purposes.
Yeah, and I think I'm pretty much on the same page with you on this. There is, I think, a tendency in our specialty where we're very results-oriented, and it's all about the photos and how good things look and the results that we get. And there, I think, in some doctors can be almost the tendency to pay almost too much attention to that. And maybe not, I mean, kind of like it's like losing sight because you're so focused on that result, and maybe you lose sight of kind of everything else around that. I think one of my fears that you haven't mentioned with fat grafting, but I'm sure maybe one of yours too, is that more and more we're learning that the fat that we have is filled with stem cells.
Correct.
And those stem cells, we didn't know this 15, 20 years ago, but those stem cells now are being used for potential medical and even cosmetic uses. Yeah. And then what would happen if you have a woman who has obviously breasts and she says, hey, let's inject some fat into my breasts. Do we know that injecting that substance that is chock full of stem cells into an organ of the body that is cancer prone, when 1 out of 9 women develop breast cancer, is there any chance that maybe those stem cells may supercharge that cancer and get that cancer to actually grow more quickly? And
that's a very good question, and we don't know the answer.
No, and so for me, I think that's a huge thing. And the more that I'm kind of studying pathogenesis of cancer and things like that, is the more I'm realizing that I think that a lot of women have subclinical breast cancer, and depending on how they live their lives, that cancer may present itself when they're 35, or it may present itself when they're 95 and they're technically in the grave. And so by doing certain things with your body, by smoking, by eating horrible foods, maybe by injecting fat into your breasts, are you going to take what could be a cancer that you would have never ever known that because it grew so slowly, and turn it into one that may be growing more aggressively. So
yeah, no, definitely. I have a master's in cancer research, and the one thing I learned during my training was that there's so much that goes on at the molecular level in the body that we don't understand, and you have to be respectful of that. There's never going to be a silver bullet and one particular cure for cancer. Every single different cell type is so different, and there's so many different ways that cell type could lose regulation and start multiplying and changing. So breast cancer is something that all women need to be concerned about. As a woman, as a plastic surgeon, and as a caregiver of breast cancer patients or women who could develop breast cancer, I would not want to put my patients at increased risk doing something just because it's trendy.
So now let's segue. I mean, you do mention, though, you do fat grafting for patients who have had breast cancer, and you're doing reconstruction.
Yeah.
So how, now we probably have people listening saying, okay, wait a minute here.
Yeah, what's the difference?
Somebody's got breast cancer, and now you're injecting fat into it, but you wouldn't do it to somebody without breast cancer.
Yeah, that's a good question.
Well, why that's okay?
Right. So as long as a woman has had a mastectomy where 99.9% of the breast tissue has been removed, she's not going to be having any more mammograms for screening. And depending on the type of the breast cancer and the stage, she will continue following up with her breast surgeon and her oncologist. When we do fat grafting to the breast, I mentioned that we inject a lot and we know most of it will go away. So maybe 30% of the fat will stay, and I'll say, well, you're not going to notice like, oh, it looks so amazing here. We've totally filled in the dent, but your donor site is going to look great, and you'll get the benefit of some liposuction at the same time. So they will continue having their breast cancer screening, but they're not going to be having ongoing mammograms. So if a woman has had just a lumpectomy and radiation, that's not someone I would do fat grafting to, because she still will have ongoing breast cancer screening. And we don't want to create more changes within a breast that's already had breast cancer.
And
some of the studies in our Plastic and Reconstructive Surgery Journal have shown that it is safe to do fat grafting to a woman who's had breast cancer. There have been no associations with potentiating new cancer or growing new cancer. So we do have the research behind us there.
Do you find that the skin that's left over from the mastectomy actually looks more youthful and tighter and looks better if you inject fat underneath that? Because that's what some doctors are claiming.
Yeah, I don't know. I think that's a tough one. The women who need fat grafting the most, who have really, really paper thin skin, maybe the mastectomy surgeon went really, really aggressive, or maybe the tumor was there. Those are the patients where we want to inject fat, but I describe it as trying to inject water into paper. It can only accept so much. Yeah. So no, fat grafting is not magic. And just like any new technology, like right now, practitioners all over the world are saying stem cells are amazing and they're using it for everything. About 5 years ago, when fat grafting started becoming popular, there were all these, quotes and saying that, oh, it can help this and help that. It's not magic. Maybe it can help to rejuvenate the area, but if the tissue is really thin and really scarred, if it's been radiated, it still is going to look like leather, and maybe replacement of that tissue with healthy tissue from elsewhere, like a flap would be better.
Mm-hmm. So now you're doing a lot of breast cancer reconstruction in your practice. And this is something that I did a lot in my residency training. I haven't done much of it in my own practice, and to the point now where I wouldn't do it because there's so many things that have changed in the last 15 years since I was in residency. And I know you're on the cutting edge of some of these treatments, especially the microsurgery. So can you explain how you're doing breast cancer reconstruction now and how that has changed in the last 10 years or so?
Yeah, definitely. So currently, I do implants. I'm a big advocate for implants for reconstruction. And if I personally had breast cancer, I don't have a lot of extra fat right now. So I would have an implant for reconstruction, and that would be great. But for women who do have some extra fat, usually in their tummy area or sometimes in their inner thigh area, when I examine them and when I get to know them, I say, okay, here are your options for breast cancer reconstruction. We can either do an implant or we can use the body's own tissue. Implants do have some advantages because we can really design whatever type of breast reconstruction you want. If you want to be bigger, we can do that. We can make it smaller. We can lift. But an implant is a foreign body, and there are always going to be limitations related to scar tissue around the implant, potential for infection. If it's infected, we might have to remove it. On the other hand, a flap is the body's own tissue, and using the body's own tissue has so many advantages. It's one operation. It's permanent. It's soft, it's warm, living tissue. It lasts forever. If you gain weight, it'll grow with you. If you lose weight, it'll lose weight with you. And after you're healed, you never need to worry about implant-related complications. When I first started training in plastic surgery, the latest and greatest were procedures that sacrificed a major muscle of the body, like the tram flap that would flip tissue up from the tummy, the latissimus flap that would take part of your lat muscle. And those are still practiced, but the problem is they sacrifice a major muscle of the body and they create big scars in an area that might be visible. So microsurgery is actually not new, but the great thing is there's so many more plastic surgeons who have training in microsurgery. And until we can do tissue engineering and grow a breast in the lab, which is going to be coming eventually, right now microsurgical breast reconstruction is the gold standard and the best thing we can offer to women.
So
in my practice,
let me just kind of explain here what she went over, because there's a lot of really cool, interesting stuff here. So when Dr. Horton and I went to residency, what you want to do is have tissue that you move from one part of the body to the breast to remake that breast. And so what we would do is take the skin and the fat from the lower tummy that is attached to a muscle, the abdominal muscle, rectus abdominis, and flip it over up onto the breast. But that in order for it to survive, it still has to be attached to that muscle. And so you would literally move a huge muscle from the abdomen up to the chest, which could, it's in and of itself, create quite a bit of recovery, discomfort, and that type of thing. The other way to do it would be to take the latissimus muscle, which is a large muscle of the back, and even though it was still attached to part of your body, you would detach a good part of it and then move it up to the chest. But that also would leave a huge scar and quite a big defect where that muscle used to be. And so the newest treatments that she's doing now literally is just taking a part of the body, detaching it, completely detaching it, and then placing it onto the breast area, and then using microsurgery, which basically is under a microscope. You literally stitch the blood vessels together to get that to survive in place. It is extraordinary surgery, very, very difficult, very technical, very time-consuming, and state-of-the-art. And I can't do it anymore. I don't have the hands and the vision and all that stuff that you microsurgeons do. So I have the utmost respect for microsurgeons and what they're doing nowadays.
Well, thank you. I honestly, I think microsurgery is amazing. And every time we do a microsurgical transplant and we sew together one artery, sometimes two veins, and we release the clamps and the blood will flow into the tissue, it is amazing. And it's almost, I always describe it to patients as it's just like an organ transplant, but instead of from one person to your body, it's one part of your body to another part of your body. So there's no chance of rejection. We will take fat where you don't need it, or you've been hanging on to it to make a new breast. Yeah. You get the benefit of either what looks like a tummy tuck down below or maybe an inner thigh lift. And it really is amazing. So it's so rewarding to do microsurgery. It is technically difficult, and I don't do it alone. I do have a microsurgical partner who is one of my teachers, Dr. Rudy Buntick, and we have so much fun working together We don't get paid a lot to do these cases. Unfortunately, insurance companies don't reimburse them well, but I don't do it for the money. I do it just because it's so interesting. And doing one of the hardest things you can do in plastic surgery, microsurgery, is just, you get a thrill every time you do it. And you get to help people.
How long would it take you to do, let's say, a one-sided reconstruction with
anywhere between 4 and 5 hours on average.
Actually, that's really good because
we are a well-oiled machine.
You guys are.
Currently, I don't work in a teaching facility, so we're not teaching residents and fellows. It's really just Dr. Buntick and I, and it's so nice. It's like a dance. It's like doing the tango because we know the steps. I do some parts, he does some parts. We do a lot together. And it's so nice to work with somebody where you don't even need to talk about what you're doing. And we often finish each other's sentences.
And I've said on this podcast in the past that there have been multiple studies that have shown that the more you do of a certain procedure, the better the results and the lower the risk of complications. And so this is the exact type of thing that if you're going to have a breast reconstruction, you're going to have a D-up flap, these types of microsurgical reconstructions, you want to go to a surgeon like Dr. Horton, where it is a well-oiled machine. 4 to 5 hours. I mean, my understanding for people in my area who have been doing these types of surgeries, I hear stories from 8 to 10 hours is how long it takes a lot of surgeons to do this, because there's such a steep learning curve.
Yeah, it can. And I think part of it is the hospital, the setup, the operating room. If you're doing a surgery where the operating room team, they're not familiar with it, it can take a long time to get the setup. If you're training residents and fellows, things go slower because they're there to learn. I learned at a teaching facility and our times were longer when I was training. But in private practice, I can choose who I work with. And I'm so fortunate to work at the same hospital where I did my training in San Francisco, where microsurgery was born about 45 years ago. Yeah. So the operating room team, they have as much pride and honor for microsurgery as we do, and it's such a great place to bring my patients.
Yeah, and you trained at the Bunkie Clinic. A good friend of mine, Dr. Sanjeev Kayastha, he's a plastic surgeon in Albany. He was there as well, so I know it's the place to go for microsurgery training.
It's a great place. Yeah, there's a lot of firsts that happen there.
So Dr. Karen Horton is a board-certified plastic surgeon practicing in the San Francisco Bay Area. She performs all sorts of cosmetic and reconstructive surgeries, focusing on the plastic surgery of the breasts and of the body for women, as well as breast reconstruction as well. You can find her at her website, drkarenhorton.com. It's Horton, drkarenhorton.com. She's also very active on Facebook, Twitter, Instagram, and Snapchat. So take a peek. Find her on her social media channels because she is great on that. Gives a lot of awesome information. Before we finish, there is a question I ask of all of our guests. As one piece of advice that you would like to give before the end of this interview, if you could have one takeaway for our listeners and our viewers, what would that be?
Okay, well, that's a tough one because I have so many messages, but the main thing I want to say is #do your homework. There are so many websites out there. There's so many, fancy sites and people that are really active on social media. And for the general observer, say you're typing in, breast augmentation or breast lift or liposuction, the first thing you see might be the person who is most aggressive with their marketing. They might have a beautiful website, but you really need to do your homework because plastic surgery is a big deal. It's your body. It's your face. It's irreversible. And when you have surgery, there's going to be scars. There's going to be downtime, and the results are permanent. So you want to do it once and you want to do it right. And doing your homework by, checking out their website, online reviews, meeting the surgeon in person. If the entire consultation is with the nurse and you meet the surgeon for 1 minute, that's not cool. I tell patients, I'm going to get to know you head to toe, inside and out. And likewise, I want my patients to get to know me, my philosophy, and know that they're really going to be cared for. So
you're doing great work out there, and I really commend you for all you're doing with educating both patients as well as even other physicians on the importance of doing their homework, choosing a board-certified plastic surgeon, a member of the American Society of Plastic Surgeons. If you're going to have plastic surgery, have it done by a plastic surgeon, not by a GYN or an ER doctor. I mean, you want somebody who knows what they're doing.
Who hasn't just done a weekend course.
No.
Yeah.
So Dr. Karen Horton can be found at her website, drkarenhorton.com. She's also very active on all the social media channels. She is a board-certified plastic surgeon in the San Francisco Bay Area. I'm assuming with your reputation, you see patients from all over the country. If you would like to see Dr. Horton, take a peek at her website and give her a call. Thank you so much for coming on the show. I think this was really educational, really informative. We hit some somewhat controversial issues here today, but I feel that you and I feel this kinship. Like, we think very similarly, because pretty much everything you said, I think the exact same way.
You're my brother. Thank you.
Thank you so much. I'm Dr. Anthony Youn, America's holistic plastic surgeon. This is the Holistic Plastic Surgery Show. We will see you next time. Do you want to look 10 years younger without having surgery? Well, my best-selling book, The Age Fix, will tell you how. I spent the past 17 years learning the secrets to turning back the clock, and have written all the best of these secrets in this book. This includes the Age Fix diet, simple changes to what you eat that can make a huge difference in your appearance. I'll share with you a simple skincare routine to keep aging and wrinkles at bay. And I'll share with you the best secrets to treat every single beauty and aging problem there is, from age spots to wrinkles, saggy skin to bad breath, saddlebags to hair loss. And almost all of these can be effectively treated without surgery. So are you ready to turn back the clock and kick Father Time's backside? If so, check out The Age Fix. Now, if you purchase it on my website, dryoun.com, you'll get over $10 off the cover price, free shipping, and you'll receive several free gifts, including a bonus chapter that you can only get by purchasing the book there. Thank you for making The Age Fix such a huge success.